updates in plastic surgery. No relevant, nothing to disclose for this lecture. So the goals for this, we're going to identify patients and disease processes that require referral to plastic surgery, articulate how to respond to patient questions about plastic surgery options and procedure, and capture how to maximize positive outcomes for plastic surgery. Really, I try to want to cover the most common things that you will see in practice that your patients will ask about and help you figure out who do I need to send to a plastic surgeon in the most common reasons. Now, if you're like Dr. Bruce, who was talking about this to me yesterday, you already know what plastic surgery is. We know it from TV, we know it from facelifts, maybe a couple nose jobs here and there, some breast augmentations, absolutely, and now the newest thing being, big butts. But really, plastic surgery is a lot more than just that. Plastic surgery, by definition, is surgery done to repair, restore, or improve lost, injured, defective, or misshapen body parts. Especially the most common thing that we're going to talk about for what makes some of the surgery I do different is the transfer of tissue from one area of the body to another. And this can be for injury or it can be for cosmetic reasons. The other question people always ask is, why is it plastic? Are you using plastic and everything? It comes from the Greek word plastikos, which means to mold. So the American Society of Plastic Surgeons does a very good job of tracking procedure trends. And so the most common for 2015, we should have the 2016 data probably here in a couple months, most common reconstructive surgeries plastic surgeons do, most commonly skin lesion or tumor removal. Basal cells, squamous cells, moles, and most of the time those are things we're looking at when you've got a mole that's in a location that's going to be difficult to close, or something like the nose, the edge of the mouth, eyelid, ear, areas where the three-dimensional structure is important in terms of how we close it and make the overall aesthetic appearance as normal as possible. The other areas, when we get larger areas, something you can imagine taking off something that's like 3 or 4 centimeters off the back, you can't really just pull that closed in a straight line. So often we'll have to use some tissue rearrangement techniques. And then you see down the line, laceration repair, maxillofacial surgery, scar revisions, and hand surgery. It's another one people kind of look at me funny when I say hand surgery. Everyone thinks about hand surgery being an orthopedic issue, which a lot of things are related to bones and tendons. But when you think about the other things in the hands, being the nerves, arteries, and skin coverage itself, plastic surgery, for the same reasons we talked about with the skin lesion and tumor removal, becomes a very natural place. Most common things we treat: Dupuytren's, carpal tunnels, ganglion cysts, trigger fingers. Cosmetic surgeries for 2015, overall breast augmentation still is #1, although the American Society of Aesthetic Plastic Surgeons has data that says liposuction has caught up or maybe slightly overtaken it. Nose reshaping, eyelid surgery, and abdominoplasty. This actually is a change where facelift has actually fallen off the list to #6, probably due to the advent of the minimally invasive techniques, Botox and fillers, and we'll talk about some of those later. This is obviously a little bit different for men versus women, and this is the Aesthetic Society's data. But you still see breast surgery, liposuction, tummy tuck, and eyelids for women. For men, facelift is still on the list, eyelids, nose, male breast reduction for gynecomastia, and liposuction surgery. I wrote out your top 5. In terms of the non-invasives, these are things, most common things being Botox and the other botulinum toxin injections, soft tissue fillers, chemical peels, laser hair removal, and dermabrasion round out your top 5 minimally invasive. The other trends we see, we talk about the most common things that's just below that list, the breast reconstruction and the male breast reduction. We've seen dramatic increases year over year, about 4% for breast reduction and 5% for gynecomastia. Men now account for 40% of all aesthetic breast reductions done in the United States. And we've seen that over the years, men have become much more willing to talk about it, much more curious, and much more accepting of the idea of plastic surgery. So it may be things you hear from your patients, and it is a very normal thing that is becoming much more popular with men. Since 2000, body contouring has dramatically increased as well. You see some of these numbers up 90 to 5,000% over what we did in 2000. And this is largely the patients who've had massive weight loss, who are getting that skin removed to fit their new body. Butt augmentation with fat grafting is up 28%. But implants are also up in the order of about 36%. That's not a procedure that I like to do. I think there's some issues related to implants in the butt, but in terms of national trends, we will do that with fat grafting here. And the lip augmentation numbers have gone up, probably mostly from the soft tissue fillers, but there actually are permanent lip implant options as well. So most common thing I talk about from a reconstructive standpoint is breast reconstruction. What's the problem? With breast cancer, it's going to affect 1 in 7 to 8 women, somewhere between 175,000 to 200,000 cases annually in the United States. And it takes a multidisciplinary approach to deal with local control, systemic treatment, and then plastic surgery comes in terms of restoration of form. Now, the diagnosis of breast cancer and the thought of losing a breast are both emotionally and psychologically terrifying for a lot of women. The good news from a reconstruction standpoint is most women who have mastectomies are going to be favorable candidates to talk about reconstruction. We can help patients identify what the best option is for them. And for many patients, it's a psychological new start to life, or I've beaten this disease and now I can see it on the outside. In terms of breast cancer treatment, if a woman's diagnosed with breast cancer, the options are going to be, the discussion is going to be had about doing lumpectomy and radiation versus mastectomy, and those are equivalent treatments. They each have their own advantages and disadvantages. Mastectomy itself is one that I'm more commonly involved with, but often when patients who've had lumpectomies and radiation can have a significant asymmetry of their breasts and will come see me, and we can talk about ways to reduce the breasts, enlarge the breasts, and promote better symmetry in the breasts. Reconstruction itself, however, is elective. The reasons patients talk about why they've had reconstruction or why they want to have reconstruction is to avoid or correct that post-mastectomy deformity. Reasons: personal, family, and sexual relations. The other thing that's important to know, because a lot of times patients don't want to ask these questions because they automatically assume that breast surgery is going to be cosmetic. Breast plastic surgery has got to be cosmetic. And there's a cosmetic piece to it, but it is reconstructed in the fact that in 1998, Congress passed the Women's Health and Cancer Care Act. And there's lots of talk about Congress and government and healthcare, but this is one that basically said, if your insurance company will cover your mastectomy, they will cover your reconstruction, period. Including surgery on the opposite breast, including nipple reconstruction, and including some degree of revision surgeries to get things as close to symmetric as possible. It's important to know that while we've made some improvements over the years, and I showed you before that breast reconstruction is up 4% since last year, and since the year 2000, our numbers have actually gone up about 35%. In 2015, we did 106,300 breast reconstructions according to the American Society numbers. Well, out of 200,000 women diagnosed with breast cancer, that's still pretty bad. Most women are going to be good candidates, and studies have found that nearly 70% of women who are eligible for breast reconstruction aren't told they have an option. One of the things that I think is great about being at Fairfield Medical Center is that I'm here. Not that that makes it great, but in terms of breast reconstruction, if you're at a hospital that doesn't have a plastic surgeon, you're much less likely to understand those options or have someone educate a patient about the options for breast reconstruction. So in poor, rural, and underserved areas, this is worse. So we've made some great strides. The American Society of Plastic Surgeons launched in 2012 a breast reconstruction awareness campaign to talk to women about closing the loop on breast cancer. Breast Reconstruction Awareness Day is the third Wednesday in the middle of October in Breast Cancer Awareness Month. And we always do something to help women understand that breast reconstruction is an option. Important to take from this is that don't assume that a woman has had her questions answered, or someone has asked her, hey, did you ever want to talk about breast reconstruction? Because we will still see patients 5, 10, 15 years after their treatment for breast cancer who are still troubled by the appearance of their breasts and wish there was something they can do, when in fact there is, but they just don't know where to ask. Education really is key. So we can do reconstruction immediately, and essentially that means we're starting the process at the time of the mastectomy. It involves some coordination between myself, the general surgeon, breast surgeons, and oncologists but it's something we're able to do and able to provide. Same thing, the biggest advantage of that is that there's a big psychological benefit. You don't wake up without a breast. It's one less surgery. It's one step closer on the road to recovery. In delayed reconstruction, like I said, this can be days to years after the mastectomy. There are some advantages in that if some patients had to have radiation or we have to figure out if they need to have radiation, we can have those questions answered and be able to give the patient the best possible treatment. Downside, there's some period of breast absence, there's some skin deficiency, and typically we'll need a little bit more in the way of expansion, but certainly can get excellent results either way. Options for women, again, no reconstruction, external prosthesis, tissue expander or implant, and using their own tissue, and most commonly that's using the latissimus muscle from the back or the rectus muscle from the abdomen. This can be done as a pedicled flap or a free flap, and essentially that means the tissue remains connected to its blood supply and tunneled through the skin to create a new breast. A free flap is one that's completely disconnected and reinserted. We don't do those here at Fairfield Medical Center, but that can be an option for some patients. And then some patients will have combination therapy where they're going to have an implant in addition to using their own tissue. In implant reconstruction, we're going to place a tissue expander in the first operation. This is done underneath the pectoralis major muscle. Adds about an hour to 2 hours to the operation if they're having it in combination with a mastectomy. Typically, you're going to stay in the hospital for a day or two, the same length as they would for the mastectomy. And then over a series of visits in the office, starting about 4 weeks out, we'll slowly expand it by using a needle placed in through this port. And this is a reinforced port, much like a chemotherapy port, that will inject saline and expand this device to stretch the skin and create an envelope for when we go in and put the permanent implant in. If a patient has had radiation or is going to have radiation, that skin doesn't stretch. It doesn't stretch well. There are times we can try and do this. The failure rate's a little bit higher, but this tends to be an easier operations for patients to do than using their own tissue, so we'll weigh the pros and cons. These are a couple different examples of expanders, and you can see they come in all sorts of different shapes and sizes. The implants that we use typically are these that have the tabs to help hold the orientation. This is that reinforced area that you can put a needle directly into. On the back, you can see this magnetic port. That allows me to use a magnet to find the spot and know exactly where we need to put it in. There's many different sizes. Allergan's got 42 different sizes of expanders we can use in breast reconstruction. Mentor's got that many, if not more, and then there are other shaped implants. Additionally, we're often using, virtually always using alloderm, which is an acellular dermal matrix, to help create a complete coverage of the expander. So this patient who's had a mastectomy, we're putting the expander underneath the muscle and then using the alloderm underneath here to help seal it off from the outside world. Types of implants, the most common ones we're going to use are going to be the silicone, the round silicone gel implants, and these are the new form-stable gummy bear implants that have a shape to them. And you can see when you cut this in half, shine it through water, it looks like a gummy bear. So in terms of the issues related to silicone implants, when you go back to the 1980s and the implants that were taken off the market, these are a very different implant. As it turns out with those, the science didn't really link to any medical problems, which led to silicone implants coming back on, but these are a much better implant than they were before. So a couple different patient examples here. This is a patient who came in, had breast cancer on the right. You can see the bruising after her biopsy. We did bilateral tissue expanders, took those out in the second operation and put a permanent silicone, this is a round silicone implant in here, nipple areolar reconstruction, some fat grafting to help smooth out the edges of the implant, and tattooing. So in 4 operation, she's got a good result that makes her, main goal we have is to look, act, and feel natural and close. All right, and you see from profile, get good projection and good restoration of the breast. This is a delayed, the patient obviously has mastectomy, comes in and gets her treatment. We've exchanged it out for a silicone implant, but you can see these areas of asymmetry. She's a little flatter up here, a little rounder right here. But you put her in a bra, and she's got a nice natural result that you wouldn't be any the wiser. You know, if she's in a bathing suit, Okay, there's a chemotherapy scar that you can see here, but other than that, you wouldn't necessarily know. The latissimus flap we take from the back. This adds about 3 to 4 hours to the operation. And basically, this is really bringing skin. I think about this, if you have a patient who's had radiation in the past, doesn't want to undergo the tram flap where we're taking the abdominal musculature, or a patient who's had a problem with an implant before and we need to bring some healthy skin in, this is a great operation to use most of the time with an implant to bring some good skin in. And like the alloderm was creating that pouch below before, this is where that muscle is sitting underneath. Again, we're still going underneath the pec muscle and using latissimus, skin, and muscle to create that coverage and closure. This is a patient who had had radiation previously, partial mastectomy, came back in for completion mastectomy, had problems with her tissue expanders, or their tissue expander on the left, primarily related to poor wound healing, most likely from the radiation, but was able to bring the latissimus muscle in from the back, and you can see the difference in the scars that she has, and you can see the difference in volume is only 50 cc's difference between the 2 silicone implants that she has in place. The tram flap, we're taking the muscle and skin from the abdomen. This is a longer operation. Patients can be in the hospital for nearly a week, but this is usually done without an implant. Patients sometimes call the tummy tuck breast reconstruction. It's a little bit of a misnomer because the abdomen, we're not concerned specifically with getting that as tight as possible. It's more about getting good healthy tissue to help reconstruct the breast. So this is a patient here who had a right-sided mastectomy. We did this actually through a nipple skin sparing technique. So she only has the scar here around what would become the nipple, and down along the side. She had a breast lift on the opposite side for symmetry, and has a nice natural result with no implant in place. On the opposite breast, like I said before, if we need to do a breast lift, if they want to have a prophylactic mastectomy, if they want to have an augmentation or a reduction, those are all covered by insurance. The other thing that's become sort of an update or a change in plastic surgery, we do a lot more fat grafting. This is something that, if you go back to the 70s, fat grafting was very, very much in favor and sort of fell out in terms of with the advent of things like Restylane and Juvederm and the soft tissue fillers, and has made its way back into plastic surgery. In reconstruction, this allows that fine tuning. If a patient has a little bit of a step off, like we saw on the one who I showed you in her bra, at the top of her implant, we can take some fat from another area of the body and move it and help smooth that area out. The Revolve here, this is a new system and how the industry has really helped sort of change the way we process fat to help increase the amount of tissue that remains viable. Nipple reconstruction, this again is elective, and I think about 40% to 60%, depending on where we are, of my patients will end up doing nipple reconstruction. Most common way, we're basically just going to lift up the skin in the same way you took a piece of construction paper back in elementary school and made a can out of it. We're going to do that with the skin to make a nipple and get projection. We often will come back and do tattooing afterwards to give a little bit more natural look. So these are patients of mine that you're going to look at just the difference between when they had the reconstruction to when they had their nipples done. And these are all implant-based, and these are all tissue-based. And the nipple reconstruction really is sort of that icing on the cake. It's the piece that it's not going to have any function, but it's the piece that when a patient catches themselves in the mirror when they get out of the shower, it fools your eye into forgetting for a second that you've had a mastectomy. So in summary, we're talking about a multidisciplinary approach. There are different options we're going to tailor to patients. This can be done years down the road. So always make sure your patients know. Every woman should have the right to choose which, if any, breast reconstruction they want to do. And insurance is going to cover it, which is always the question your patients are going to ask. Other things in terms of changes in the way we do breast reconstruction has evolved. There's been a lot of push, you saw in terms of skin-sparing mastectomy. There's different things in terms of nipple-sparing mastectomies. Real-time imaging of skin flaps to help prevent tissue loss. The silicone implant sizes. Currently, the largest silicone implant you can get in the United States is 800 cc's. You saw the one which was 700, and that was not a overly large woman. in some of our patients, we need a bigger size, and those are currently under study to get an FDA approval, up to about 1,500 cc's, which would be a great benefit for larger women who are having breast reconstruction. And also, there's been some move towards using implants above the muscle to help decrease patient pain afterwards as well. Bariatric surgery. Bariatric surgery is increasingly becoming treatment of choice for a lot of weight loss patients, but most of them are not aware that additional plastic surgery is often going to be needed to help them fit into their new body, both from a physical and psychological standpoint. If you go back 10 years, this is something that insurance companies were not that unlikely to cover. They probably would have. In 2016, as there's been an increased demand in anything, they have tightened their regulations on who can get what they will cover. So when a patient has rapid weight loss or has a bariatric surgery, typically they're going to have an initial rapid weight loss phase. When they reach a plateau for about 2 to 3 months, that's when we talk about surgery. This is typically about 12 to 18 months after their massive weight loss procedure. And what we do is, based on their BMI, where they are, what their expected weight loss was, but patients should realize it's going to often involve multiple surgeries. Most common areas, patients will talk about the hanging abdominal skin, deflated arms and breasts, upper and lower body, thighs, buttocks, and also accelerated facial aging. In 2013 statistics, we can see almost 42,000 procedures done on patients who had had bariatric surgery. And like I said, as patient demand continues to increase, insurance company coverage becomes a little bit more stringent. So this is, if you ask me, this is reconstruction of the skin. The skin's been stretched out, but insurance companies want to consider things cosmetic unless they have specific physical reasons to have surgery. And I pulled a couple of policies, and this is Anthem's policy on the abdomen. Essentially, the things that we're looking for when a patient asks, would my insurance maybe cover this? Does the skin hang below the level of the pubis? Not the pubic bone, but all the way down, so you're basically covering things onto the thigh. Then you have documented recurrent or chronic rashes, infections, cellulitis, or non-healing ulcers. One of the insurance company updates we got for this year says chronic rash is no longer an indication. You've got to have cellulitis, you've got to have infection, you've got to have antibiotics or hospitalization for them to consider covering a paniculectomy. They also want to see conventional treatments for a period of 3 months, documented. I had a patient come in for a breast reduction along the same issue with rashes underneath her breasts and met all the criteria. I had a letter from her primary care physician that said, yes, I've been treating this patient for the past year for these complaints. And the insurance company said, yeah, we need to see your office notes, and it's not in your office notes that you documented that you did this. So they have to wait 6 months and prove that it's a problem before we go ahead and talk about doing surgery. That's the biggest takeaway is document. And they need to see that the treatments have been unsuccessful. If they've had bariatric surgery, they're also going to have requirements related to how much weight they've lost. At least going to be at least 100 pounds, BMI under 30, or a weight loss of 40% or greater of the excess body weight that was present prior to the surgery. Paniculectomy, this is sort of in their policy, but it contradicts itself on the next slide. It says, if you're doing this in where you have to do it in another surgery for exposure, then we can cover paniculectomy. And the next line says, it's not covered as an adjunct to other medically necessary procedures, such as hysterectomy, interstitial ventral hernia, and this is probably the most common one that we'll try to talk about, unless they've met those other criteria related to rashes, irritation, and skin breakdown. It also then gets into a little bit the description between what's a paniculectomy and what's an abdominoplasty, and I'll show you that a little bit here later. For arms, thighs, and buttocks, it's even less specific. It basically says you've got to have significant physical functional impairment. It's got to persist despite optimal medical management with no definition of what that is, and the procedure is reasonably expected to improve that physical functional impairment. I can tell you in our office, we try as best we can. Arms, thighs, and buttock lifts are rarely covered. If patients have medical issues related to smoking, previous open gallbladder, hernias, these may change the way that we're going to approach their surgery. And also, they've had gastric bypass. The issues related to malabsorption, anemia, dumping syndromes, we've got to make sure we've got those things under control as well. Preoperative testing is essentially the same as we would do for any other surgery. For the abdomen, the difference between a paniculectomy and abdominoplasty is whether you're dealing with the upper part of the abdomen or not. Paniculectomy is essentially taking that skin that hangs off the bottom, cutting that off, and leaving this all lax as it is. An abdominoplasty, which is a more cosmetic operation, is going to pull that extra skin down. And instead of having that incision be here, pull that incision up to here, pull that down, tighten the muscles. That is a more cosmetic operation. This is an insurance operation. This is a paniculectomy. The contour of the abdomen isn't changed, but it's this hanging skin that's causing these chronic problems, this chronic irritation, that can be a significant impact and improvement on a patient's life. This is a patient who has gastric bypass, lost over 100 pounds, but it's just treating that loose skin. You see she's got this old incision here from her open gastric bypass, so we're going to use it when we tighten the skin here. Again, a couple different examples of the changes that we can make. Body lift, again, this is more encompassing the buttock lift, the posterior lift, along with the abdominal part. It essentially involves a circumferential tightening. So again, we're going to tighten the muscles, remove the excess skin, and remove the excess skin along the backside to give some lifting and shape to the buttocks, as well as dealing with that loose skin. So some patient examples we have here. This is a woman who has, again, most of these patients are all going to be at least a year to a year and a half out from their bariatric surgery, and we're sort of contouring their skin to fit their new skin on, fit their new body. One of my old professors used to say, essentially, if you had clothes that you had from before your gastric bypass that you want to be able to wear, you're going to take them to the tailor, and they're going to pleat them and take things out and make them fit your body, fit you now. We're doing essentially the same thing with the skin. All right, you see we get that lifting and shaping here and that roundness through my watering, I'm sorry, to the backside. And again, patients, especially if they've had an open gastric bypass, it allows this opportunity to use the skin to pull in as well as down and get a better contour. This is a male patient, had achieved dramatic weight loss, was down, his BMI, I think at the time of surgery was like 26, and can do that contouring and shape. And we're going to shape the male buttocks a little bit differently than we will a female. The biggest downside of this is often this, whether it's male or female, will sort of flatten the backside. And there are different techniques we can do to try and maintain that. For breast, most patients who've had massive weight loss aren't going to be able to talk about breast reduction because they've typically lost a lot of the volume from the breast as well. If they have an adequate volume of the breast to be removed, then sometimes we can document the problems of macromastia, then we will be able to come in and try and go through insurance for that breast reduction. Most of the time, patients will be getting the breast lift to reposition the skin, reshape the deflated, droopy breast, with or without an augment to restore some of the volume they've lost. So here's a patient, and this was done in 2 operations. I wish I had her first pictures in here. I thought she had actually a great result from her first. It just wasn't large enough. And so we switched her out from that mid-range profile to a high-profile implant to give that fuller volume. This is a patient, this is just implants. Didn't have a lot of breast tissue to begin with. We talked about lift, and she certainly could benefit from that, but again, it's meeting the patient's goals. She had this in conjunction with doing her arms as well. Another patient done in conjunction with a breast lift, implants, and tummy. And I'll show you those same pictures again, but again, now to focus back on his chest in terms of dealing with his hanging skin and giving a more aesthetic male upper body. And for him, we did take this around to the back and do more of an upper body lift to tighten some of that loose skin up in here. For the thighs or the arms, incisions, now these become a little bit tougher for patients because these are incisions that are going to be visible. What you saw on the breasts and on the abdomen are ones that are going to be hidden in clothes, hidden in the bathing suit. For the arms, now you've got a scar that's going to be visible in a tank top, visible in a short sleeve shirt, or potentially. The thighs, shorts, is going to typically come down to the level of the knee. But these are ones, and like I said, these can, patients often will describe that bat wing deformity. That's probably the most common thing people will talk about wanting to fix. And in terms of examples, here's a patient, massive weight loss. You can see how that bat wing that hangs down here, and the incision healed very well, but you can see it just here along the medial aspect of the arm. From the back, you can't see it, and when her arms are down on her side, it sort of sits right against the skin. Another patient example, again, done in conjunction with with a breast lift and implant. And this is a scar that comes down and actually runs all the way around and connects into her breast reduction scar, so we get some of this tightness of this lateral chest wall skin. This is not a full thigh lift, but this is one of the rare cases I've gotten an insurance company to agree with doing a medically necessary thigh procedure. You can see the chronic induration, chronic paniculitis of this, and so by resecting that, and didn't do anything with the rest of the thighs, it allows him to walk without what he called a bowling ball strapped to his leg. And a thinner patient, again, dealing mostly with that loose skin to tighten this and contour. You see the scar that goes along the groin and down the medial thigh. For breast reduction, this is both a cosmetic and a reconstructive operation. We talked before about a certain percentage of these are going to be aesthetic in nature, primarily when they don't meet insurance criteria. But we're going to create breasts that are smaller, lighter, and more proportionate to the body. Patients report increased self-confidence and comfort in clothes and activity. You can talk about breast reduction through both excision techniques and liposuction techniques. I have never done one with a liposuction only technique because you don't get the same breast lift phenomenon. Most patients have loose skin, and in my hands, I think that, and in most plastic surgeons, we're going to do this through excisional techniques. Scars are often well hidden in clothing or bathing suits. It is one of the most common reconstructive plastic surgeries if you were to hit number 6 on that list I put up before. Most common thing a patient will say to me afterwards, I wish I did this 5 years ago. Again, don't be afraid to mention to your patients, hey, this is an option. Now, of course, your insurance company is going to give you pages and pages of what we're going to look for. The take home from this is really it's the documentation of these problems. This particular insurance company says at least a year. Most of them are going to be 3 to 6 months. Headaches, back pain, neck pain, shoulder pain, kyphosis documented by x-rays, bra straps that cut into the shoulders, skin breakdown, or numbness and tingling down the arms. They want to see that patients have had documented that they've had non-steroidals, prescription medications in terms of analgesics, dermatologic therapy of the ulcers or necrosis underneath the skin, physical therapy referrals, chiropractor referrals, the use of proper support bra, medically supervised weight loss programs, or if they've had to go see an orthopedic or spine surgeon for pain. Those are things that we have those documented, those are things that are going to help patients. The other thing often is insurance companies are often going to equate their approval based on how heavy the patient is and how much weight we're going to take off. And that's something, once we get past that, we will look at it in my office and help the patient figure out if we're going to, how much weight needs to come off to meet a more proportionate size to their body. Some pictures we have here in terms of reduction. Typically, every breast reduction is going to have some degree of a breast lift to it, and often some reduction in the size of the areola to fit the new shape of the breast. Older women, younger women, and again, just something that feels better. One of the things that amazes me is when a patient in the recovery room, when they're waking up, they're like, how you doing? Like, my back feels better already. I'm like, okay, well, it's been 10 minutes since your surgery. Not really. but it's often they'll say that and they can feel that strain sort of lifted right away. This is an earlier picture to show where those scars are around the nipple, down the front, and underneath. And as those fade, those will be very well hidden and very accepted by patients. In terms of what's new in minimally invasive procedures, going back to hand surgery for Dupuytren's contracture, this has been around for a couple years, but there's an injection called Xiaflex. This is a prescription medication that's a specific collagenase that we can inject into the cord of Dupuytren's cord and dissolve it, and in a non-surgical approach. Basically, the patient comes into the office, we feel the cord, assuming they've met insurance criteria, inject the medication and hold their hand still for a day. They come in the next day, remove the splint or dressing we put on, and through a manual palpation, actually just pop the cord. It's very similar to the old sort of fasciotomy that we did or the closed fasciotomy for a Dupuytren's contracture, but you are getting a dissolution of the cord for approximately a few millimeters, and that's going to be enough to hopefully prevent that recurrence. The problem is you can only do up to 2 cords in one hand during one office visit. It doesn't remove the cord, so that palpable that firm cord in the hand that may be painful for patients isn't treated. I still think open fasciectomy, the surgical procedure to remove that, is the treatment of choice. But if you have a patient who's older, isn't going to tolerate or just doesn't want to undergo anesthesia, this is another option that exists for them. Kybella is one that's come out about a little bit over a year ago. This is one your patients may start asking about because Allergan, who makes it, is starting to market it direct to consumer a little bit more. This is a deoxycholic acid injected into the submental fat to dissolve the fat. And these are from Allergan, their pictures. It's a series of injections, and that's a permanent removal of fat. Again, sort of to compete with the idea of doing liposuction underneath the neck or other minimally invasive procedures. Now, this is a series of injections. Patients do get swelling afterwards, but it's becoming more and more common, and patients that I've had have been very, very happy with these results. For facial injections, this is almost changing on a daily basis. Obviously, Botox has been around in the United States since 2002, and the hyaluronic acid soon came after that, largely replacing collagen. But within the past couple years, we've had new releases of Voluma, which is more designed to treat the mid-face, Volbella specifically for the lips, Restylane Silk specifically for the lips. L-polylactic acid is a medication called Sculptra, which was originally used for patients with severe atrophy from HIV and AIDS. And people said, well, wait a minute, aesthetically, that's just really a hyper-accelerated view of aging in the face, and took that and adopted that to the cosmetic indication a few years ago. The other biggest change in terms of facial injections and the way that I do them is we've gone away from the idea of let's just fill the lines down here in the lower part of the face. It used to be, and you'll see that Hollywood, sometimes you'll see this overfilled, full lower part of the face, the jaw becomes a little bit widened, and it becomes a little bit unnatural. The normal aesthetics of the face, the youthful face, is this inverted triangle. You should be fuller in the mid-face than you are down in the chin. And so with Voluma or Sculptra, by focusing more on the mid-face, you actually get a better, more natural rejuvenation with injections. The other thing is you'll see, and we've seen over the years, all sorts of different minimally invasive body contouring techniques and body contouring devices. The gold standard is liposuction for what this is. And liposuction to me is a surgical operation. I know you'll see it done, and some people will do liposuction in their offices or advertise that with no anesthesia. This is surgery, and this is why I think liposuction should be in the hands of a plastic surgeon, because you have to know what can go wrong and be prepared for all those eventualities. But some of the things with laser liposuction, such as smart lipo, which you don't hear much about, but was all the rave about 5 years ago, Low-level light therapy was Zerona, and there's a few new ones that have come out. In my opinion, don't do much. Radiofrequency techniques have been around for a while, and there's multiple different ones. The Apollo tripolar is the one we have in the office. And this is a nice technique. It helps tighten skin, reduce fat. It's not what I can do with the liposuction, but for somebody who doesn't want to have surgery or doesn't and can accept a slightly lesser result or doesn't need that much, it's a great option. But there's a bunch of different devices on the market. Ulthera is one your patients may ask about. This is using ultrasound. And all of these, essentially, ultrasound, radiofrequency, laser, or the low-level light, are trying to create heat to melt fat, essentially. Ultrasound can be painful. Some of the radiofrequencies sometimes, well, the tripolar is really nice because it's not painful. It feels like a warm stone massage. And the other one, which is all over everywhere now, you'll see is Coolsculpting, which is actually freezing the fat. This is a nice technology. I don't have it in my office. There are some things related to it. You know, their studies show about a 28% reduction in the fat. So again, that's good. It's not what we can do with surgery. There are some things, there can be some pain associated with it and some long-term nerve sensation changes that we've heard of. But it's another option that's there. We don't have it here, but it's something your patients may ask about. I still stick with the tried and true surgery. So that's what I've got for updates for what's new, what's most common in plastic surgery. I want to make sure we have time to open up to whatever questions exist. Yeah?
As far as family medicine goes, like for pre-op and post-op patient, I was curious about the healing process. There wasn't much really on healing. Are there any recommendations you can have for like supplements or topical cream or something? I know I've heard of like vitamin E and stuff like that, but is there anything you suggest or recommend?
In terms of scar recovery, I mean, I think the data on scar recovery and scar healing talks about vitamin E, steroids,